Ladies and gentlemen, welcome once again to another episode of the Think Clinical Podcast. My name is Hamza. Always great to be here. Please remember to subscribe, like, and share as we talk through very important topics in the healthcare, business, entrepreneurship space. Today we're going to be looking at another topic on AI, and we're going to be looking at why we need to be looking at total cost of ownership as a measure of value compared to our traditional way of looking at everything from a return on investment or an ROI standpoint, which is the traditional way to look at it. Usually when it comes to some of these interventions, the question is what's the ROI? But then what we need to be asking is what's the total cost of ownership if we actually want to look at the total value of especially an AI product that we are adopting. So actually I'll walk through this, and hopefully we should be able to get some perspective into this, because when we talk about the ROI, it's mostly a retrospective metric, and we designed that for mostly capital equipment and not for technology that are adaptive in nature like AI, that usually have to change behavior, they have to change workflow, and it has to change decision making over a period of time. It becomes difficult to use the traditional ROI metrics to be able to measure such a tool. So when Stanford, for instance, implemented the AI sepsis prediction tool in 2022, the initial AI calculations showed that it break even at best, right? But a study revealed that the real value, which is clinicians who use the tool, develop better pattern recognition, they improve diagnostic accuracy even without AI's assistance. The cognitive spillover effect, which measured by traditional ROI, represented millions of avoided harm, millions. So that wasn't factored into the initial calculation of the ROI, so that was where it was. So let's establish why traditional ROI fails in healthcare AI. So the three fundamental problems. One, we have the time horizon mismatch. So most healthcare systems calculate ROI on a 12 to 24 months basis, right? But when we talk about tools or items like AI, which has to be done over a period of time, usually the research shows that behavior change from AI adoption usually takes about 18 to 36 months to fully manifest. So when you're like if you look at a study that tracks the AI diagnosis tool, they found peak performance improvements which occurred in year 3. But we are looking at mostly AI ROI in a 12 to 24 month period. So that's one problem, or one fundamental problem. Second one is that we have attribution complexity. So when outcomes improve after AI implementation, the question is what really cost it? Is it the algorithm? Is it workflow redesign? Is it the staff training? Is it the hot-on effect of being monitored? Is it the healthcare operation complex? Basically, what we are trying to say here is that healthcare literally operates in very complex systems. So you cannot isolate causality in many of these situations. So that's the second thing that we need to pay attention to when we are looking at why these are fundamental problems. The third one is the value displacement. So AI often shifts value between departments or time periods. So if you look at again a diagnostic AI that might increase surgical costs but decrease downstream treatment expenses and readmissions, we have to be able to look at this more objectively, because when you look at traditional AI, it usually would capture cost increases and misses the benefit displacement. That's what I mean. So what research actually shows is that a 2024 Health Affairs analysis of 47 hospitals who were implementing AI found only 12% projected ROI, or 12% met the projected ROI targets in 1 year, but 68% exceeded projections by year 3 when measuring the total cost of ownership. And that's why I want us to look deeper into this and look at when looking at AI systems or adaptive tools like that, instead of looking at just the return on investment, why don't we look at the total cost of ownership? What does that mean? When you replace ROI with total cost of ownership and the whole value framework, these are the cost components that we are looking at. We are looking at the direct cost, which is from licensing, implementation, infrastructure. You're looking at indirect costs, which is training, workflow disruption, opportunity cost of leadership. You're looking at hidden costs, which is technical debt, data quality improvements, and maintenance, right? You're looking at exit costs, what happens if the tool fails or you switch vendors, right? Now, the value component of this would be in the option value, which AI creates organizational capability for future innovations. Like when we talk about R&D, it builds absorptive capacity, right? When we look at the learning value, staff develop new competencies because they're just not using the tool, they're learning from it. And a lot of the time, like in Hopkins, for instance, there was the AI tool that helped do triage. It demonstrated 23% better clinical reasoning on paper-based assessments. So, and then we have the resilience value. So AI can provide a surge in capacity during crisis. So during COVID, hospitals with predictive capacity models adapted staffing 30% faster than peers because they were able to predict what the need would be in the next couple of weeks. And then we have the signaling value. So we are looking at this from a total cost and the value component. And that's why switching it, if you look at this just from an ROI standpoint, you miss all these components that I'm talking about right now. So these aren't easily quantified, I need to admit that, and that doesn't make them less real. So healthcare executives are comfortable making subjective calls about hospital culture should extend the same judgment to AI calls. And one of my episodes I talked about hospital culture versus psychological safety. You should be able to make the same subjective calls here, because all the things I just mentioned up there, you cannot measure them. So when you look at the alternative metrics that may matter, instead of chasing ROI, you can actually measure what actually predicts success. You can measure clinical utilization rate. You can measure time to proficiency. You can measure error detection rate, and you can look at workflow friction. These are some of the things that you can actually look at. And when you talk about your intermediate indicators, you can look at skill transfer, you can look at process standardization, you can look at cognitive load reduction, you can look at decision confidence. When you look at your lagging outcomes, you can look at patient safety events, you can look at length of stay adjusted for acuity, you can look at clinical retention in AI and all that. So these are some of the things that you can actually look into. So when we talk about ROI, we also have to look at when ROI analysis actively harms innovation, because the uncomfortable truth here is that when you demand ROI proof, it can kill valuable innovation. And that's where we have to be very careful what is the sweet spot here. So traditional ROI analysis, when we look at the precautionary principle problem, for instance, traditional ROI analysis favors the status quo. It actually would ask, prove this new thing will generate returns. But it rarely asks, what's the cost of not innovating, right? So that's the first thing. The second one I'll talk about is the streetlight effect. So when we measure what's measurable, not what matters. So AI impact on clinician cognitive load, diagnostic thinking, and adaptive capacity are real. They are, but hard to quantify. So we focus on scheduling efficiencies and time savings, which don't speak directly what the true impact of that is. So the alternative approach, which is the portfolio theory, is that venture capital doesn't expect every investment to generate ROI, that's for sure, but they build portfolios where wins offset losses, and healthcare should adopt a similar thinking. So you have 20% core tools with proven values must generate positive ROI, 50% growth tools, emerging evidence measured by leading indicators, and 30% exploratory tools, learning investments measured by organization capacity. This is how a venture capitalist portfolio looks like mostly. So you have the 20% core tools that have proven value and would generate a positive ROI, and you have the 50% growth tools, which I imagine, and they are measured by leading indicators, and the 30% exploratory tools, which you really are not looking at to this. And so we need to replace ROI with what problem. First of all, ask yourself, what problem does this solve that we can't solve otherwise? 2, what will we learn from implementing this? 3, how does this build organizational capacity? And 4, what's your hypothesis about value creation and how we'll test it? And then create transparency, not justification. And always document assumptions openly. We expect this amount of efficiency gain based on Y evidence. We are uncertain about Z. Here's how we'll measure it. This might fail. Here's our leading plan to getting it. So the key principle, and the question here is, the question isn't does AI generate ROI, but we are building an organization capable of leveraging AI to create multidimensional value, and that's where we need to look at the total cost of investment and the value that is going to bring out. And that's the more strategic question to ask than what the return on investment is, because that becomes very difficult, especially in the context of healthcare. This has been another episode of Think Clinical Podcast. I hope this has been helpful. Please remember to subscribe, like, and share, and we'll see you in our next episode.